guys got it going? Yeah, okay. All right. We'll go ahead and get started. I actually like this slide here. The human brain, most complex, amazing of all the creatures on Earth. Researchers learning more about how it works every day. So much is still unknown. Psychiatry and modern medicine has come a long way in the last 100 years. I guess you could say that again. And then we now understand much better how to help those who suffer with mood disorders. But many doctors and therapists agree support groups are extremely beneficial, an important way to round out a treatment plan. All right. So we also do VA groups. We were doing in-person. We were doing inpatient at the VA. Usually our groups are all outpatient. But we're getting back to that eventually. So I'm going to back out of this here. If you guys want to get yours ready, and then I'll go ahead and say a few words here.
So you need this one. Sorry.
Yep. So welcome everybody to tonight's lecture. Good to see you here. Let me stand over here. Excuse me. So our organization has a long and well-established presence here in the Tampa Bay community as an advocate to individuals suffering with mood disorders, and we'll continue on with that into the future with our partners in healthcare and education. We established our organization here, or actually we established our support group here on the campus of USF over 30 years ago with the encouragement of former Psychiatry Department Head Dr. Anthony Redding, as well as Dr. David Sheehan. We met here 52 weeks a year, with the only gap occurring during the 3 years of the COVID pandemic. Actually, it was about 2 years, but then we couldn't get back in for the final year. So a quick calculation indicates roughly 1,560 90-minute support groups were held in this very room, with an average of 14 individuals attending per meeting. That equates to approximately 21,840 diagnosed individuals walking through that door to get support as an adjunct to their doctor's treatment plan. In addition to our many weekly support groups held in Hillsborough, Pinellas, and Sarasota counties, we are proud to have a continuous series of our lecture workshop events hosted free for the general public. And these educational programs, in addition to being informative, will also help to dispel the stigma of behavioral health diagnosis, as well as contribute to individuals seeking professional mental health care for themselves or a loved one or family member. So at this time, I'd like to introduce DBS Tampa Bay Director Dr. R.J. Morris, MD, to elaborate further and introduce tonight's speakers.
Yeah, I don't know if I need it, but okay. I'm only going to be standing up here for. Is this helping at all?
Yes.
Okay, good, perfect. So as John said, my name is Robert Morris, Dr. Morris. I'm a general practitioner, but I've been lucky enough to be part of DBSA, both as a member of the board as well as a group facilitator. I run the Monday brain group meetings. And I really just appreciate everything that this organization does, and I'm very proud to be a part of it. So I appreciate John letting me just come in and do a brief introduction. In addition to the weekly support group meetings that we run, we also try to provide educational resources, and we do this through one of the ways we do this is through the Aiken Lecture Series. And what this is really just an opportunity for physicians and mental health professionals in the area to really just kind of provide, through a lecture type series, just general information and how they can help themselves as far as how they can work with their own disorders, help others, and really just provide just an outlet for those physicians and mental professionals to kind of reach out to our local community. Approximately 1 year ago, that kind of thought process of mine, we kind of came up with the idea of, well, we do have a couple psychiatry residencies in the area, so we wanted to reach out. And from day one, I reached out to, I'm going to try and say this right, the USF Morsani College of Medicine Psychiatric Residency. And it was just, the response we got was just very, almost overwhelmingly positive and enthusiastic. I mean, they were really, from the go, just really wanted to help us out and really wanted to be here. So they held their first lecture a year ago on bipolar, and it was fantastic. And so we really appreciate them coming back in here today to present to you all. For those of you who aren't familiar, the way our medical education works here in the United States, you do 4 years of undergrad at university, then you go to 4 years of medical school, and then you have an additional 3 to 4 years, sometimes more, depending on your specialty in the residency program. And it's that residency program here today that's going to be presenting the lecture. And I just want to point out that the time for residents is pretty precious to them. They work long hours, do full shifts, 6 to 7 days a week. I remember when I was in residency, if we had 2 days off in a weekend, we used to call it a golden weekend because it was just that rare. So it's just, we greatly appreciate you guys coming in. I'm sure you guys worked all day just to come in and talk with us, so I do want to say thank you. So again, greatly appreciate you guys coming in. I won't belabor this too much, so I just want to go ahead and introduce Dr. Danemen, Dr. Homsey, and Dr. Dolan.
Thank you everybody for having us. We appreciate you being here. I wish I went to more tech school, that's all I can say. So.
Better?
So we wanted to talk about something that's very important to mental health overall, but particularly important in depression and bipolar disorder, is that sleep. I think everybody here has been in a situation where they're not sleeping enough, they're feeling terrible, tired, irritable, and it's something that only exacerbates other mental disorders. So something very near and dear to my heart is getting a good night's rest. So some of the things we want to talk about is how the how sleep works, what it actually means, some of the different drugs or medications you may encounter in the world that affect sleep, and some of the things you can do yourself to get yourself a good night's rest.
All right, so we're going to go into first our overview about how sleep impacts bipolar disorder. Bipolar is kind of the focus here, but this also will, of course, have relevance to depression as well, because depressive episodes are often part of bipolar disorder. So first off, we want to emphasize that sleep problems are a part of this disease process. They're not a personal failing. And even outside of bipolar disorder, people struggle to sleep. In the United States, in our demanding work culture, people are getting less and less sleep. And honestly, when I talk to patients, even when I talk to just people I know, I'm surprised when people say that they're sleeping well. It's more often than not that people complain about sleep, how difficult it is just to get to sleep. Even when I talk to my parents, especially as people age, right, it becomes difficult to get to sleep and to stay asleep. So it's not a personal failing by any means. Insomnia is something that is just so common to struggle with. So we'll start with some numbers just to kind of put it into context. About 69 to 99% of people with bipolar disorder have lessened sleep need during a hypomanic or manic episode. And we'll go into what exactly defines less sleep need versus things like insomnia, hypersomnia. But that's a huge, huge percentage. The majority of people with mania or hypomania are going to have decreased sleep need. And then 38 to 78% of people with bipolar disorder have increased sleeping or hypersomnia during episodes. And this is often during episodes of depression more than anything. But what I found really remarkable is that about 70% of people with bipolar disorder still have sleep disturbances, either insomnia, decreased sleep need, or hypersomnia, even when they're not in a current mood episode. These things tend to persist even while people are what we call euthymic, meaning they're not in a current episode of either mania, hypomania, or depression. It's very common for it to persist. So a little bit more into what these terms really mean in terms of what really makes decreased sleep need a part of mania. So this is actually a hallmark of mania or hypomania. It means that you sleep very little. And there's no exact time amount, but I start to get concerned when I hear a patient saying, I sleep for only 1, 2, 3, 4 hours, but I still feel refreshed and energetic. That's what really gets our alarms up as physicians and mental health counselors, therapists, anybody in the mental health world. We start to get worried when people say, over consecutive nights, I'm not sleeping very much, but I don't feel tired. That's decreased sleep need, and it's part of the major diagnostic criteria for mania or hypomania. On the other side of the spectrum, in depression, we can see either hypersomnia or insomnia. And insomnia is when you have that difficulty either falling asleep or staying asleep, or both. And then hypersomnia is sleeping more than you normally would. I couldn't find an exact hour number. I mean, different places kind of cite different numbers, but usually it's somewhere like 10, 11, sometimes up to 13 or 14 hours in a night. That's usually not normal for most people, and all of this ultimately is still about a pattern for you. If you normally sleep, a certain 6 or 7, maybe 8 hours a night, suddenly you start sleeping a lot more or a lot less, that's really when we get concerned. So ultimately it needs to be individualized. But insomnia and hypersomnia can be part of depression. So first we'll talk a bit about sleep disturbances and mania. The whole phenomenon of having decreased sleep need is actually really important and common prodrome, or a symptom that leads into mania. It's oftentimes the first thing that people will notice. Even before they have the major mood changes that they'll start to notice, even before they start kind of feeling on top of the world, or like they can do a lot of projects, or maybe taking some chances that they otherwise wouldn't, doing things that are impulsive. We often see that in the majority of cases, there's this prodrome of sleeping less and less. Reduced sleep itself is also an important trigger for manic and hypomanic episodes. So this can be kind of a precipitating factor. If somebody stays up more due to shift work or due to thinking that they have to pull an all-nighter, well, if you have a bipolar disposition, then that can be actually pretty dangerous and can lead into a major mood episode. I did look into some of the brain changes, and I won't get into the really granular details in terms of what they've seen genetically and in terms of like circadian rhythm changes, but overall there are studies that suggest that there is some decreased melatonin secretion and maybe a delayed melatonin peak in people with bipolar disorder. But ultimately, a lot of these studies point towards sleep deprivation being a common final pathway to mania. So a lot of things can kind of lead into that sleep deprivation, but it's one of the riskiest times for people to have a major manic or hypomanic episode. Then we'll talk a little bit about the sleep disturbances and depression. So people with bipolar depression often have more fragmented REM sleep, and REM sleep is very important in terms of the restorative qualities of sleep. They take longer to get to sleep, and they have lower sleep continuity. Even in studies of people without bipolar disorder, you'll see that if you sleep deprive them, you'll often see negative changes in mood over time. Poor sleep quality and nightmares can increase the risk of self-harm as well. We actually see that impulsivity increases with any kind of insomnia, sleep deprivation. And sleep deprivation or sleep disturbances while you're euthymic, as in not in an active episode, can contribute to residual depressive symptoms. So that's kind of, when you think back to that 70% of people who still have some sleep disturbances even while they're euthymic, even though they're not in a current mood episode, they might still report things like having a low mood or feeling more irritable than normal. They might not meet full criteria, but these are still things that we want to know about and consider, because ultimately, you know, helping out with your sleep is something that we as physicians can often do to help make sure that you maintain a good level of stability. A little bit in terms of the health impacts of insomnia. I wanted to emphasize this because oftentimes, you know, if you have a decreased sleep need and you still feel rested and refreshed, you might not really think about it being a danger to your health. And that's, you know, it's understandable, because if you feel fine, then oftentimes people don't think that there's a need to reach out and get help. But if you have decreased sleep over time, if you have sleep deprivation, it has effects on cognitive function, especially in terms of planning, making good decisions. It's got these effects on mood regulation, and it's also pretty detrimental to immune system health. So, you know, what we ultimately recommend is that if, you know, your family members or your friends, or even, you know, I don't have a smartwatch or a Fitbit or anything like that, but I've heard that a lot of them track sleep and the amount of sleep that you're getting based off of things like heart rate variability, restlessness. It might be a good idea to take a look at that and see if there are any, you know, major changes in terms of what it's recording. I don't know exactly how reliable those things are, but if they're telling you that you're sleeping less than usual, I think that it's important to keep an eye on it, because it's often that important early warning sign, or maybe a canary in the coal mine, that you could be at higher risk of a mood episode. And, you know, these are things that we can help out a lot with in terms of counseling and medications. So, you know, make sure to share that information with your doctor if you feel like you're sleeping less or sleeping more than you normally do. And on to our next section.
All right, so I just want to talk a little bit about some of the medications, some of the drugs, some of the substances that can impact sleep. So, show of hands, who here woke up today and had some coffee? Good. We're like the average American. Caffeine is one of the most utilized drugs in the United States. And why do we use caffeine, right? It perks us up, wakes us up in the morning. I'm not myself until I've had my coffee. But one of the problems with caffeine, if it keeps you up, it keeps you awake. And many people